Any question from the audience, please?
That was really interesting. And I must say thank you for some up-to-date data. I actually hadn't seen the antioxidant data. I think the problem with macrolides and antibiotics to me is that we have few studies on the microbiology of what's getting on. And I have to now admit to the floor, and Nick was very nice about our study, the macrolide study in our department was done when we were moving from East London to North London. And we didn't realize that the microbiology was so different in the two institutions, and we couldn't combine the data. So now I'm leaving all my microbiology at UCL. We're not even trying to move it. And actually, I think we're short on that. You know, we also, there's no biopsy studies. Nobody's done any biopsy study of macrolides to see are they anti-inflammatory, are they anti-infective. Sputum we didn't show anything at all, nor did, I think, the Albert study, Rick Albert's study in the US, hasn't really shown any significant anti-inflammatory action. So perhaps it's time to go back to a little bit more basics. Are we actually reducing bacteria? Because that's important, I think, also from the bronchiectasis phenotype. So I'd be interested in your comments.
Yes, you're right. I think it's a mixture of effects, and in fact, in the Albert study, there was a reduction in strains at the end of the day in the group taking the macrolides. But I think the problem we have is that inflammation is so complex, and it's not just COPD and not just smoking, it's just also having bacteria, and perhaps not all bacteria have the same pro-inflammatory effects, that at the end of the day, by measuring 1, 2, 3, 4, 5, even 10 different biomarkers, we may not see really the real effect of the drug in a significant number of patients. So it's so complex that we are just looking through a small window what is going on there. And I think that this does not rule out the possible anti-inflammatory effect of the drug that I think is existing. And also there was a paper in thorax of the group from this American study looking at some protein that I never heard about it before, looking at the effect of the macrolide on this protein that apparently has a very important antibacterial, anti-infective effect, so justifying the clinical impact. So I think that we now know, and we should be more confident by looking at the studies in CF and in non-CF bronchiectasis, because at the end of the day, our patients with COPD do have bronchiectasis. And I don't think that these bronchiectasis are very, very different from the bronchiectasis that appear in a patient who is not a smoker and who may have bronchiectasis for other reasons. At the end of the day, they are bronchiectasis, they have the same bacteria there, and they probably need the same treatments.
Yeah, and maybe something that could be interesting, well, it's probably also a question of fashion, but you might imagine that macrolides, through their antibiotics effects, are able to, I don't know how you say that, re-equilibrate the airway microbiota, which, I mean, the effect of macrolides has not been much studied on this. Maybe there is something, just a hypothesis for lunch.
May I? One question. Did you quote the Pantheon study? Because I had to go out. Yeah, there is a paper on another Chinese study on that it came on the Lancet Respiratory Medicine, but which is similar to the previous one, so no comment. Now, I think that you actually propose, and I'm sure you agree, that there is a subpopulation where it's warranted. And you define it. And I think that for us practicing, you know, if you have one with 2 hospitalizations, taking 3 or 4 times a year antibiotics, and is on everything, I think that you would consider Now the question to you is, from the review of the literature, is any molecule that is the most reliable, is it azithromycin, and you have to screen for cardiovascular risk first, and then or erythromycin that has been more. What would you recommend? I mean, if you end up with the practical recommendation.
Yeah, I think we have to screen for prolonged QTC and for other drugs that may interfere with these cardiovascular risks. and also for non-tuberculous mycobacteria before we started long-term treatment. And regarding the drug, I mean, there are studies with different drugs, but we have more evidence now with azithromycin, and also not just for COPD, but also for bronchiectasis and CF. So I cannot say which one is best from obviously from my own experience, but I think that they're accumulating evidence with azithromycin that can be more effective than other macrolides.
Yeah, and easier to use also, which is all my patients are on, these patients are azithromycin. A bit more expensive, but...
Just few more comments. One on the Professor Fabri publication of the Pantheon, the editorial by Mario Cazzola, the accompanying editorial showing exactly the same conclusion of Nicolas Roche. So maybe something connected with different diet, whatever, or genes. And the other one on the same line of the comment of Visha, from my personal opinion, why we should really prescribe one expensive drug with potential serious side effects when we still don't know how it's acting. Basically, we know as if it's an antibiotic effect, anyway, we know it's changing the ecological, we have ecological hazards. If it's an anti-inflammatory effect, why we should not try before a very good clinical trials in the same patients where we can add azithromycin, instead we don't try low-dose theophylline. We never did. It's very expensive because nobody funds. Nobody's funds. We're trying. Yeah. But
I think.
Yeah.
I think.
As you heard, he was training Peter Barnes' lab. So
yes.
Well, in fact, I thought you were talking about inhaled steroids because you said an expensive drug that we don't know how it works and we don't, and the safety.
Thank you to everyone.